Hello everyone. Today we'll be discussing two cases of pilocytic astrocytoma with RCSM Medical College postgraduate students. So this is case number one, 11-year-old girl, known case of cerebellar pilocytic astrocytoma who was operated 4 years ago, complaint of headache for 1 month. A large lobulated altered signal intensity mass measures 5.5 into 5 into 3 centimeters in the cerebellum involving the vermis and both the cerebellar lobes. It showed heterogeneous contrast enhancement with central areas of necrosis. Previously, her scan was done, that is in 2019, and then it was a fairly large, well-defined abnormal signal intensity mass, which measured 4.6 into 4.4 into 4.5 centimeters with perilesional edema. Now, this time she underwent a midline suboccipital craniotomy. The tumor was excised and sent to lab. This is a case too of a 14-year-old boy. You can see the cerebellum shows a typical solid cystic tumor, and the tumor on T2 weighted and post gadolinium weighted images reveal a large cystic lesion. You can see this is a large cystic lesion and a solid mural nodule. So coming to the imaging findings of cerebellar pilocytic astrocytomas, these are typically well circumscribed solid cystic tumors. Characteristically, they have a cyst with an enhancing mural nodule. There may be little or no surrounding edema, and they often present or cause obstructive hydrocephalus. Now, calcification may be present in 20% of cases approximately, and hemorrhage is rare. These are often contrast enhancing with solid tumor component, typically iso to hypo intense on T1 and hyper intense on T2 weighted images. Orbital pilocytic astrocytomas are also common, and these present as enlarged optic nerve chiasm or tract with variable enhancement. Uh, the pilocytic astrocytomas associated with NF1 are solid, and they usually do not extend beyond the optic pathway. And the non-NF1 associated pilocytic astrocytomas are cystic in nature and extend beyond the optic pathway. Now, these tumors characteristically have dotted eye appearance on imaging. The differential diagnosis in pediatric age group for a cerebellar tumor, which are usually solid cystic, could be medulloblastomas, ependymomas, hemangioblastomas, and atypical teratoid rhabdoid tumors. Coming to histopathology, the pilocytic astrocytomas present with a wide range of morphology in the neoplastic cells. Now, this morphology may vary from pyloid appearance to oligodendrocyte appearance, and at places the tumor cells may be multinucleated and have a stacked appearance. That is, they may have multinucleated horseshoe cells, which gives appearance of pennies on a plate pattern. Now the pattern which is commonly present is a biphasic pattern with compact areas and loose areas. Now, compact areas are composed of spindle-celled astrocytes or the pyloid cells. Uh, these are typically the bipolar cells which have oval to elongated bland nuclei and moderate cytoplasm. Okay, and these are present on the fibrillary background. These are admixed with the Rosenthal fibers. And the other pattern is a loose cystic area. The loose areas, these are edematous and they have these typical microcystic appearance with myxoid material. And there are oligodendrocyte-like areas. Now, one should not mistaken this for a oligodendroglioma. Now, Rosenthal fibers are, they are very typically elongated purplish pink fibers. These are typically found in the pilocytic astrocytomas, these and eosinophilic granular bodies in variable proportions. Rosenthal fibers may also be found in the non-neoplastic tissues, that is, the tumors which are slow growing, and the peripheral part of the tumor may show presence of these pyloid structures. So, for example, a suprasellar craniopharyngioma or a hemangioblastoma in peripheral portion of these tumors, these pyloid structures may be present. So one should not mistaken these for pilocytic astrocytoma. You should look for the components of craniopharyngioma and the hemangioblastomas. Okay, so these are the eosinophilic granular bodies. Now one should not mistaken eosinophilic granular bodies for aggregates of the red blood cells. The degenerative changes may be found. That is, we already saw the microcystic degeneration, hyalinization of the blood vessels, and the infarction necrosis. Now, the infarction necrosis should not be mistaken for a high-grade glial tumor, that is a glioblastoma. And in the cellular pattern, this is one pattern, that is perivascular rosetoid pattern. You can see the perivascular rosetoid arrangement of the neoplastic cells. So should not be mistaken for a case of appendix. Another feature which may be found in pilocytic astrocytoma is the glomeruloid microvascular proliferation. Now, this should not be mistaken for the microvascular proliferation found in the grade 4 glial tumors. One must also remember that the non-Rosenthal fibers may be found in gangliogliomas, pleomorphic xanthoastrocytomas, and in non-tumor, that is non-neoplastic lesion, a genetic disorder, that is Alexander's disease. Coming to immunoprofile, these are GFAP OLIC2 positive tumors. They are IDH non-mutant. P16 is retained, SOX10 is positive, ATRX is retained. We do P53, which is weak or absent. Synaptophysin, EMA are negative, and the proliferation index is very low. So these are the diagnostic criteria for classic pilocytic astrocytomas as per WHO 5th edition recommendation. In the essential criteria, these are classic histological features of pilocytic astrocytomas such as biphasic compact and loose growth patterns, pyloid cytology, and low proliferative activity with or without Rosenthal fibers and or eosinophilic granular bodies, or a low-grade pyloid astrocytic tumor with solitary MAPK alteration such as Kia 1549 BRAF fusions. In the case one, we did NGS and we studied 52 genes and fusion drivers. And what we found is this case was typically positive for Kia 1549 BRAF fusions. So, both the cases we rendered a diagnosis of pilocytic astrocytoma, CNS WHO grade. Let us quickly go over the discussion. Pilocytic astrocytomas commonly affect children and young adults below 20 years of age. These account for 5.4% of all the brain tumors and about 17.6% of all childhood primary brain tumors. Clinical features: focal neurological deficits or non-localizing signs such as macrocephaly, headache, endocrinopathy, and raised ICT. Optic gliomas may cause visual loss. In localization, they may arise in any area where astrocytes are present. In pediatric population, infratentorial region, cerebellum is most common. The other preferred sites include optic nerve, optic chiasm, hypothalamus, thalamus, basal ganglion. Spinal cord and ventricular are less frequently involved than the brain. Coming to interop cytology squash, we do squash as well as frozen in our setup, Shanti Lab. And no, the smears will be typically low to moderate cellular, showing Rosenthal fibers, bipolar astrocytes, and the background shows thin fibrillary processes, occasional pleomorphism of the neoplastic astrocytes may be present, and occasional endothelial hyperplasia may also be present. However, mitosis is sparse or absent. Coming to genetic profile, 60% of pilocytic astrocytomas demonstrate Kia 1549 BRAF fusions. NF1 mutations are common in 10 to 15%. BRAF V600E are may be found in 5 to 10% of cases. KRAS mutations may be present. Now, this FGFR mutations or fusions, these are more common in the adults, and these are also found in other low-grade gliomas. And these cells, these tumors, they typically exhibit oligodendrocyte-like morphology. One must also remember that H3K27M mutation may be present in few cases, but only when it is a midline tumor. It should be labeled as a diffuse midline glioma. So coming to prognosis, these are slow growing low grade tumors with favorable prognosis even after multiple progressions. They rarely recur when completely resected, and they may favorably respond to targeted MEK inhibition. The subtypes are pilomyxoid astrocytoma and pilocytic astrocytoma with histologic anaplasia, and these are likely to behave aggressively. I hope you like these two cases. Thank you very much.